and I will let everybody in.
Great. Yes.
All right. Good morning, everybody.
Good morning.
So
Good morning.
nice to have you here. We have a special guest this morning, and I'm going to introduce her. She is Dr. Barbara Tailor. She's an obstetrician and gynecologist who retired from active practice in 2001. Despite having a law degree and a master's in business, her true passion has always been helping women. In 2008, she published the first edition of her book, Menopause Management Your Way, Now and for the Rest of Your Life. In 2016, she began delivering her unbiased, comprehensive education on on menopause on YouTube, where she has almost 100,000 followers. Dr. Tailor sees herself as a teacher and a tailor of women's health and menopause. And of course, this is her book, more than 600 pages.
Teacher and a
welcome.
tailor, no pun intended, huh?
Teacher and tailor. It works.
It works.
It's true.
Oh, that's good. I like that. I like that.
So thank you. That's an introduction of Dr. Tailor. And so Dr. Tailor, I was wondering, most of Dr. Montgomery's patients are of perimenopausal and menopausal age. I'm going to let some more people in. And I'm wondering if you might speak, as long as you feel necessary, about the Women's Health Initiative study. That was the study that seemed to take all women, most women, off of hormone replacement therapy. It gave everyone, it seems, the impression that hormone replacement therapy causes cancer. I notice in your book that the healthy women studied, 50% of them were smokers, 33% were overweight, 33% had high blood pressure. Their median age was 63, older than when most women begin hormone replacement therapy, and that women with severe menopausal symptoms were excluded from the study. So that's sort of the one thing I was hoping we might discuss. And then in episode, Dr. Tailor has a YouTube channel, as I mentioned, with almost 100,000 followers, but from episode 1 to episode 300 and something, you're getting an education in menopause. And episode 292, timeframes for the development of diseases due to estrogen deficiency. We looked at this graph here, and I'm wondering if you might speak to it, because I believe that in the plant-based community, somehow we think that we are immune to estrogen loss because of the way that we eat. And I wonder if you might speak to that. So heart attack, osteoporosis, and Alzheimer's.
Well, you know, first of all, you need to think of estrogen as your fountain of youth. Estrogen is what keeps your body young on the inside and the outside while your body is producing it. So when we go through menopause, what happens is we lose our fountain of youth. And so what happens is we start aging on both the inside and the outside. And it just so happens that the aging process on the inside of our bodies entails 3 things. Our heart arteries go from being soft and supple like this to getting stiffer, to becoming hard, which is where we get the term hardening of the arteries. That's the aging process of our heart, most of which was prevented by estrogen. Our bones go from being dense to being osteoporotic. That's the aging process of our bones. And our brains are covered with estrogen receptors that are fuel for our brain. They make our brain function beautifully. And the aging process for our brain is shrinkage, which is Alzheimer's, because the estrogen receptors are empty. So it's like your brain is running on fumes. So when it came to the WHI, the main focus of the WHI was heart attack. And the key question with the WHI was, can HRT prevent heart attacks? Not does it cause heart attacks, can it prevent heart attacks? And then they tacked on a bunch of other things, you know, just other things to look at besides heart attack, but they designed the study for a heart attack. Well, the problem is they used women who were on average age 63. Well, if these women, if the average age of menopause is 51.2, if all these women had gone for 10 or more years with no estrogen, that means that they were already on the road to hardening of the arteries. So the aging process had already begun. And then they gave them estrogen and they said, well, can it prevent a heart attack? Well, when these women went on to have the diseases that they would have with aging because they lost their fountain of youth, they blamed it on the hormones. So an analogy would be if you took a bunch of insulin-dependent diabetics and they took their insulin, but they also still ended up having some go blind and some have renal failure and some have amputated limbs, would they blame it on the insulin? You know, this is how you have to understand what this study did, but they didn't keep their focus on prevention. Instead of reporting the results to women in terms of no, HRT won't prevent a heart attack if you're already at risk for heart disease, if you've already developed hardening of your arteries. Instead, they said, oh no, it causes a heart attack. They're two different things and they require two different study designs and they're done in two completely different ways, but they switched gears in the study and told you something that they hadn't studied. That is the big prevailing problem of the whole study. And they did it with everything. They then went on to say, well, it causes Alzheimer's. But it was like, no, these women were already going to get these things. They already had the beginnings of the diseases. The HRT just couldn't stop it or prevent it or turn it around. And we already knew that. It's not, HRT doesn't fix these things. It just prevents them. There's a big difference.
That's a great point you raise. I wasn't aware of that aspect of the study, but the actual point you raise is very, very common in medical science, misinterpretation of data. And I've seen that in so many articles presented in New England Journal, et cetera, that, and these are astute clinicians. I remember as a trainee in going in internal medicine, I was going into cardiac electrophysiology. There was a study that came out comparing electrophysiology studies to Holter's, and you looked at the findings and people misinterpreted that study.
Exactly.
And it happens all the time. And so I'm glad you pointed that out. And that's one thing I think for our audience to understand is that when you look at the headlines in the press, as the press is in the news about science all the time, don't just look at the headlines. Try to look at the data, go to someone like Dr. Taylor, myself, like yourself, and say, let's talk about this and analyze the studies, because it happens a lot. I think that's a great point. And I wasn't aware of that regarding that study. I was aware of the study and those findings, but the point you made, starting at age 63 is important.
Yeah, it's huge. It's huge. And another thing about studies is I always tell women, never focus on a single study, because in medicine, every study is just a small piece of a puzzle with like 1,000 pieces. No one study is the final word. No one study gets to be the Bible. We don't have Bibles in medicine. So each study contributes one piece of the puzzle, but one study leads to our decision to do a different study and then the next study. And so they all only address a tiny, tiny bit. And when a person says, oh, but this study, and then they think that that's everything, it's like you're missing the boat. When I present studies on my YouTube channel, I present the whole sequence of studies that got us to where we are today. And I just put them in order and I said, well, this study showed us this. So then we studied this and then we got this. And it's like, you can see the progression, you can see the course of events and why they studied the next thing, or sometimes you're scratching your head as to why they studied the next thing. But then you have to take into account the fact that there's funding involved and there's different players involved and people have different goals and objectives. And come on, that's always going to be part of the equation.
Yeah, yeah. And the studies have to build on each other, as you point out. And there also has to be a fundamental biochemical aspect to things. So if you do a study saying, well, eating grapefruit does X, Y, and Z, you also need to have some basic science studies that show some pathological, biological evidence or suggestion as to why that's true.
That's right.
And so you have to build on things that have to be consistency from the biochemical aspect or the basic aspect to the clinical findings. And if you don't see that consistency, then you have to step back and say, well, what are we missing here?
Right.
And so, but anyway, that's fantastic.
Yeah.
Go on, Jack. I'm going to let you lead.
So
this.
I was just going to ask, this study studied Premarin,
Yes.
and Prempro, correct?
Premarin and Provera. Provera is methoxyprogesterone acetate. So it's a form of progesterone.
And both of those are, do both come from a horse?
No, Premarin is a brand name.
Yes.
Premarin is pregnant mare urine. Premarin. It is the only estrogen product that has anything to do with mares. It is the first estrogen product ever produced back in the 1940s. And it is estrogen only. It is conjugated estrogens, meaning all of the estrogen in a horse. A horse has over 11 kinds of estrogen. We females have only 3. But Premarin contains all the ones that we have, plus some from a horse, but it's one single product. That was the first estrogen ever developed, and they did the study only using that estrogen, but now we have many, 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 many others, and they haven't done any studies like this. The big thing about the WHI is that it was the most expensive study ever done. It was a $1 billion study. Is why everyone treated it like the Bible. But no, it was, they broke all the rules of science. They manipulated the data. They broke through. I know all the people who did it. They broke all the rules and still they got away with it because it was such a big study. Well, Premarin isn't used very much anymore. I mean, there's nothing wrong with it. Look, I tell people there's no right, wrong, better, worse, good, bad, or best. Those are marketing words. Women are not robots. We should all do whatever's right for us individually and don't worry about what everyone else is doing. But nowadays, everyone's got something to say and an opinion and a reason to put something down. It's like your body's opinion is the only one that's going to matter. Either you're going to do what your body wants or you're going to be very unhappy. It doesn't matter whether you like it or not. Your body doesn't care what you think or what you read or what you heard or what you prefer or what you believe in. Your body just doesn't care. It's like expecting my hair to care if I heard about straight hair being better and finding thousands of studies to prove it. My hair doesn't care. So this is the same way it is for your body. So Premarin, some women do great on Premarin. Some women love it. For 50, 60 years, it was the only hormone out there. You meet a woman who was taking Premarin, she's 100 years old and she's as snappy as she can be because they took estrogen replacement. And it doesn't matter whether it comes from a horse or a plant or this or that. It really doesn't matter. It's a matter of how does your body use it and respond to it. Progesterone comes in many, 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 many different forms too. Medroxyprogesterone acetate was one of the very first, and it is, and I don't like this. I don't like these words. I don't like the words synthetic and natural. I don't like those words because they're very misused. Okay. People think of natural as better. It's not better. It's whatever your body wants. Some people do much better on a synthetic than a natural product. It just doesn't matter what the label is. But medroxyprogesterone acetate is not one of the most used progesterones anymore either. So now you have this big study done with hormones that hardly anyone uses that much anymore. And everyone's still using the study as if it's dogma. So that's a problem too. You mentioned something earlier, Jackie, about the plant-based community and how the plant-based community says, yes, but if I'm a plant-based person, I have a 100% plant-based diet, I don't need to worry about this estrogen loss and estrogen deficiency matter. Well, two things of importance here. Number one, when you lose your fountain of youth, that aging process begins. And you saw on that graph that you showed on the screen that it just gradually increases. The risks for all three of these diseases just gradually increase with time. The problem with adopting the mentality that I'm plant-based and therefore I don't need to worry about menopause, which is estrogen deficiency, is that that is a huge, huge oversight of the fact that nutrition is nutrition, exercise is exercise, and a hormone is a hormone. They will never do each other's jobs. You cannot get your exercise from your food. You cannot get your food from your exercise, and you cannot get any of those things without a hormone. A hormone will only do the hormone's job. Food and exercise will never be a hormone. Does an insulin-dependent diabetic say, "Oh, I'm gonna manage my insulin with my food and exercise"? No. Okay. Every hormone deficiency on planet Earth, every hormone was produced by your body for a reason, meaning your body can't live without it. And every hormone deficiency on planet Earth produces a long list of symptoms that tell you something is missing. You feel horrible. And if you don't replace the hormone, there are fatal diseases that ensue over time, period. It doesn't matter what the hormone is. With thyroid hormone deficiency, if you don't replace it, there are fatal diseases. With insulin deficiency, there are the basic science of hormone deficiencies is the same no matter what the name of the hormone. And so when you start adopting these rules that are magical thinking, you will get into trouble. So it's great to have a 100% plant-based diet, and it definitely is the diet that is absolutely best for your heart and will help you decrease the risk for heart attack no matter what your situation. But it's not going to take the place of estrogen. It's not going to do that.
There was comments, related to the World Health study, Women's Health Initiative study. And one thing I recall coming out of there is that topical hormones were safe, quote unquote, compared to the oral ingested hormones. What are your thoughts on that?
Well, here's the science behind it. Any hormone, estrogen, progesterone, testosterone, any hormone that has to go through your digestive tract in order to get into your bloodstream has to transfer through your liver. In the liver, there's a slightly increased risk of blood clots. That is the only issue at hand here, a slightly increased risk of blood clots. Now, what's the biggest risk in the world for a blood clot?
Well, inflammation, a sedentary lifestyle, inflammation, et cetera.
The biggest risk in the world for a blood clot is pregnancy. How many women worry about a blood clot then? None. Okay, women worry about all the wrong things at the wrong times. Okay, pregnancy is the biggest risk in the world for a blood clot. The second biggest risk is a genetic mutation for a blood clot. The third biggest risk is a previous blood clot. The fourth biggest risk is morbid obesity. The fifth is immobility. The sixth is smoking. For most women addressing menopause management at about the age of 50, a blood clot doesn't amount to a hill of beans for them personally. But when they say, "Oh, but I've heard about a blood clot," I'm like, well, but are you going to make your decisions around something you heard? Or are you going to apply it to yourself and decide whether or not it warrants any consideration? And most women don't need to be weighing a blood clot hardly at all, unless you've had some of the risk factors that are pertinent. But this is where the tailoring comes in. If you're worried about stuff that doesn't apply to you, you're going to fail. So tailoring is everything. If you don't tailor everything to you specifically, you're doomed. I mean, there's no way you're going to make good management decisions when you're worried about something you heard that is irrelevant. Okay, and so this is why I always say getting the education is very important, but what's more important is having everything tailored specifically to your situation, because I can tell you so many women have so many more options than they realize simply because they're ruling out things for no good reason.
Well, that's a good point about the tailoring, because every patient doesn't fit in that study profile. And
no, not at all.
Counseling someone that, like you said, who's like 51, 52, about to go through menopause or early phases. They said, well, what should I do about hormone replacement? I said, well, you know, WHI says no, but you're not a WHI.
I always say they didn't study you.
Exactly.
I always tell them they didn't study you. And I say, you know what? Get the education, see how it applies to you, and then you can do whatever you want, but at least you know what you're doing. You know, the big difference in what I do and what some other people in the so-called hormone or menopause world do is this. Most people tell you the risks of taking HRT, but that's not the whole story. I tell you the benefits of taking HRT, the risks of taking HRT, and the risks of not taking HRT. That is the whole story. It's a three-legged stool, and you deserve to know all three parts of it. And without knowing all three parts of it, you are being cheated of the whole education. When you learn that there are more sides to it than just the risks, then you realize, oh, wait, it's trade-offs, just like everything else in life. You know, you get in your car, it's trade-offs, benefit, everything you do all day is benefit risk. This is no different. But when you get the whole story, you can make great decisions for yourself. When you only get terrorism, you can't.
And the salient components of those three legs again are what? Let's say you're counseling any one of our clients, and they say, well, should I take hormones or not? Let's say you had a hypothetical 51-year-old about to go through menopause, et cetera. What are those three legs?
Let's say a woman is 51, she's going through menopause, her quality of life is horrible because there are literally 22 symptoms of estrogen deficiency, not just one. There's hot flashes, night sweats, anxiety, mood swings, irritability, depression, joint pain, hair loss, dry vagina, skin changes, urinary incontinence, urinary tract infections, weight gain, loss of sex drive. I mean, it goes on and on. Most women have no idea that all of this is one thing. They are busy running to 15 different doctors thinking that each thing is separate. Well, guess what? You don't have 15 things. You have one thing. You have estrogen deficiency. It's like thyroid hormone deficiency. If you had that, you would have dry skin, you would have dry hair, you would have weight gain, you would be fatigued, you would have no energy. It's all one thing. That's how hormones work. One hormone loss causes about 15 symptoms. Well, if you know the symptoms of estrogen deficiency, you can do something about it. So a woman who's, say, 51, she's going through menopause, perimenopause, transitioning, or she's already there, either one, and she's miserable. And her marriage is falling apart. She can't function at work, and she's just having a hard time making ends meet day to day functionally. If she says, well, but I'm worried about breast cancer, and I teach her what her risks for breast cancer are based on her situation, and I teach her that estrogen deficiency puts you at high risk for heart attack, osteoporosis, and Alzheimer's, I'll say to her, which one's more important to you? Which one weighs more? See, she can decide. That's her decision. That is her. Most women's knowledge of breast cancer is so completely upside down and backward because the entire world of breast cancer is completely governed by fear, not logic. Fear has run the whole train. And so they're all worried about breast cancer, and they don't realize that their biggest risk is a heart attack. Heart attacks kill 1 out of every 2 women who have a heart attack. Breast cancer kills 1 out of every 29 women who have breast cancer. Why are you more worried about the breast cancer? It's one of the most curable cancers on our planet. We find it early. The survival rates are fantastic. There's like 100% survival rate up to stage 3. So it doesn't make sense to just be afraid of the wrong thing and just not know all the facts. And so this is what my teaching is about. I teach you all the facts, and you get to do whatever you want, and I'll help you do whatever you want. But I want you to know everything before you start deciding what to do.
It's a great point, because oftentimes people are worried about hypothetical problems when there's a real problem facing them. So here your situation that you described, your life is falling apart, you have all these symptoms. So here's a real problem. There's 100% problem here without your hormone, but then you're not going to take it because there's a theoretical 1 into the 10th power problem you're avoiding. So, but you're not fixing the problem that's taking care of you. So. Yeah. And we do it in other aspects of medicine, unfortunately. Sometimes on mid-levels, we have a patient getting ready for surgery, and and they're, you know, an anticoagulant for atrial fibrillation, for example. So, you know, we got to stop this, but, you know, we're going to stop this anticoagulant for the surgery. But so, well, that's a real problem. You have to stop it for the surgery. There's a theoretical risk of a stroke, which, you know, is one in, you know, hundreds of thousands. But, you know, if they go in under the knife with the anticoagulant, that's a real problem of excess bleeding. So let's stop the anticoagulant. So
Again,
you have to make those common sense decisions sometimes.
It's trade-offs. Everything in life is trade-offs. And I teach these women, I say, you know, you have to decide how much weight to put on each factor, whether it's a benefit or risk, whatever it is. It's her, each woman has the right to assign the weight that works best for her under her circumstances. And I tell them, look, fear has weight too. And you are allowed to say, yes, I'm doing this purely out of fear, but just know the difference. Know what is fact and know what is fear. And, you know, one of the things I say to women is I say, you know, HRT is like, I always say, did you see anything weird about COVID? Anything at all that was weird about COVID? And they all start laughing. And I go, well, HRT is the COVID of menopause. And I say, because when you think about it, anytime you have fact and fear, the facts get thrown out the window, the scientists become quacks, the science becomes bogus, and the fear runs the show. And that is exactly what you saw with COVID. And that is exactly what has happened in the world of menopause. Fear is running the whole show. And fear paralyzes brains so that no one stops to think about anything. You know, I say to women, I say, do you hear men saying that their testosterone is bad for them and it'll kill them and cause cancer? They go, no. I say, do insulin-dependent diabetics say that about their insulin? They go, no. I say, do thyroid deficient people say that about thyroid hormone? They say, no. I said, well, then why do you believe that about estrogen? They go, by the way, you walked around for like 35 or 40 years with your body producing a bucket of estrogen, and then you lost it one day and you started feeling horrible. If it's poison and it's going to kill you and cause cancer, why didn't it strike you dead back when you had the bucket? Why did you feel good with it? Why do you feel horrible without it? These are the thoughts that you would have entertained had you not been terrorized by fear. But fear made it so that you didn't dare question the fear.
Too much of medicine is run by fear. I mean, that's an amazing point. People get bypass surgeries, all sorts of therapies based on fear. And it is an amazing, I'm glad you raised that point, because it's amazing. It's an amazing driving force behind a lot of medical decisions that are made here in the United States. And it's an amazing sales tactic.
Absolutely.
So it's used, it's leveraged greatly to push decisions among doctors and patients and other, you know, healthcare.
Fear is the most powerful emotion on earth. It's the most powerful emotion on earth. It paralyzes people. If you want to get someone to do something or refrain from doing something, just scare them. It's the best marketing tool that ever existed. And so much in the world of medicine is governed or promoted by fear. It's sad, but it's the truth.
I'll tell you, it's amazing. It's amazing.
We have Can I ask one question, Dr. Taylor? Have they done any studies on bioidentical hormones?
Yes, they have done studies. In fact, they've looked at the WHI for the last 20 years, and they found that almost all of it is bogus and should be thrown out, and everything about it was a mess. And the researchers have been backpedaling ever since. But see, you've never heard that because the media didn't think of it as something dramatic enough to sensationalize. And you know, I always say, don't get your medical information from the media. Good Lord. I mean, their job is, they have no knowledge of medicine. They have no business reporting it. And yet they do. And when they do, you get the wrong message. But the WHI itself has been reevaluated over and over and over again in many different ways, shapes, and different angles. And most of it has been completely debunked. But you haven't heard that. And the guidelines are all still governed by the WHI. All the guidelines that doctors follow 20 years later are all still, I mean, the guidelines, because of the WHI, say HRT, give it in the lowest dosage for the shortest time. Okay, I ask you, have you ever heard an insulin-dependent diabetic say, I'm going to take my insulin in the lowest dosage for the shortest time? Doesn't it sound stupid? I mean, a hormone deficiency is a hormone deficiency. You take the hormone replacement for the rest of your life and you take it in a dosage to prevent the fatal diseases. How in the world did they get away with the mantra, lowest dosage, shortest time? I guarantee you most doctors are practicing according to that mantra. That's a problem. And their guidelines also say only give HRT for severe symptoms of menopause, not to prevent the diseases, severe symptoms. So if I teach my students, I say, you've learned all this logic from me and you've learned about these diseases. You can't go into your doctor and say, I want HRT to prevent a heart attack, osteoporosis, and Alzheimer's. They will slam the door in your face because they have guidelines that say the only reason you can give HRT is severe symptoms of menopause. So I tell them, if you want HRT, you're going to have to go in and say, oh my God, my vagina's on fire and I can't sleep and my husband hates me and I'm going to lose my job. Okay, show them severe symptoms of menopause. That is the only way you're going to get this stuff. And they're always going, oh my God. And I say, you have to play a game. I say, it's not fair. It's not logical. But because of the craziness that ensued from the WHI, that is what you have to do. It's insane.
Yeah.
No insulin-dependent diabetic has to do that.
That's I like the way you make those comparisons to other hormone deficiencies because we don't think of it in that manner. And it has, and again, I've been influenced by this. Of course, I haven't, I was in training at the time of the WHI, when that data came out, and I think our institution participated in some of that, was one of the centers. So I was in my other mindset, since I've been in private practice, I've been working and thinking outside of the box. But I'm glad you're sharing this information because I haven't applied that outside of the box thinking to this particular topic. Because
I always say just substitute the word insulin for the word estrogen, and there's your logic. There's the logic of hormone deficiencies in general. You can always do whatever you want, but at least you now have the logic that you can kind of say, well, wait a minute, why does everyone say estrogen is different? Well, it's not. It's just that there's fear involved.
No, that's exactly right. This is amazing. Someone has a question. I'm 61. I use topical plant-based progesterones in the 40s and 50s. QLEX stopped in late 50s. I did not have uncomfortable menopause that I know. Question: how do I measure, how best do I measure my hormones, blood, hair, saliva, and what levels do I supplement estrogen?
Well, here's the thing about hormone levels. When it comes to your thyroid or insulin, your body always produces those for the rest of your life, right? Your body was designed to produce those for the rest of your life, which means that there is always a normal range for those hormones. There is a normal range. You get your blood drawn, you check, are you in the normal range? And then you go from there. Estrogen is different. Why? Well, it's because we are not supposed to live long enough to lose our estrogen. Mother Nature's plan for all animals is birth, reproduction, and death. And other animals don't have menopause. The only reason we have menopause is because we have had so many scientific and medical advances that we are living so long now that we are literally outliving our ovaries. There's nothing natural about it. We were not supposed to outlive our ovaries. We were supposed to die. Okay, so we now have a hormone deficiency that our bodies were never, ever prepared to deal with. So there is no such thing as a normal estrogen level in a postmenopausal woman. Menopause makes your hormones go from here to zero. They all go to zero. So a lab means nothing. Not only is a lab a snapshot in time, but it doesn't have any meaning when there's no such thing as a normal value. So any doctor, any manager who uses labs to manage your menopause, guess what's going to happen? You're going to say, oh my God, but I still can't sleep and I'm feeling horrible and my skin's dry, my hair's falling out and I'm fatigued. And they're going to go, oh, but you're right where I want you. Goodbye. Okay. Listen to your body. If it's very simple, your body talks to you. If your body has enough estrogen, you will have 0 symptoms of estrogen deficiency, right? Logic. Okay, and if you have enough estrogen, you will not lose any bone. And if you have enough estrogen, your lipids and cholesterol and triglycerides will be stable. The reason is this is all the same stuff estrogen used to do for you. So if you take enough now, it'll be the same. See, this is logic. If the estrogen accomplished all these goals before, if you take enough now, it will accomplish the same goals now. If you don't take enough, or if you take none at all, these diseases of aging will start and your symptoms will be there. It's so easy to listen to your body. The problem is humans are horrible at it. Humans are busy listening to Dr. Google and Suzanne Summers and all the marketing and advertising and hype and scare tactics and labs and studies and girlfriends. And, I mean, this is the problem. Everyone's asking other people what they should do, when in fact, your own body is telling you loudly and clearly what it wants.
So one question, follow-up to that, related to the levels. So if someone comes in and let's say their levels are in the postmenopausal range, and okay, maybe they're having some symptoms, so they supplement to the point that the symptoms are suppressed and they're feeling better, but the levels are lower. Could one make the argument to get the levels up to the premenopausal level to prevent heart attack? I mean, because the prevention of heart attack is another aspect that goes beyond symptoms.
It depends on the person. If that woman who now has no symptoms has her cholesterol studies drawn and it still shows that her cholesterol is rising, which is the first step toward a heart attack. I mean, all these women who run out of estrogen and go through menopause, they all say to me, I don't understand it. My cholesterol just gets higher and higher and higher. I'm not doing anything differently. Exactly. Okay, so let's say her cholesterol studies are still going crazy. Well, that's her own body telling her that's not enough for her. On the other hand, if her cholesterol levels stabilize and everything remains nice and stable and she finds out she's not losing any bone, that's her own body saying to her, this is enough for you. But we aren't robots. Women aren't robots. We can't plug everybody into a box or a range or anything. There is never going to be a time when we all metabolize estrogen the same way or need the same dosages of estrogen. And we aren't even talking about women who are prematurely menopause or suddenly menopausal. If your menopause is early, premature, like younger than age 45, it's a whole different ballgame because you start the race for the diseases sooner. If your menopause is sudden, like with surgery, chemotherapy, or radiation therapy, rather than gradual, which is 2 to 10 years of transitioning, that's another big difference because both premature and sudden menopause are a much bigger shock to the body. Okay. So you have to take every single thing into account. And when you're listening to other people, you're never going to be doing that. You're going to just be shooting from the hip and reacting to everything you hear. And I try to make sure women don't do that. I go, you shouldn't care what anybody else is doing. And I get them so educated in a consultation. Jackie will tell you, I warn them, I say, you now know 90% more than most physicians. And they do, because I send them a document about almost 100 pages, plus or minus, depending on the woman. They're all about 100 pages long. And I basically teach you everything and tailor it to you. And I warn you, doctors don't know this stuff. There's no education on menopause in medical school. We don't get a minute. Do you remember getting menopause in medical school? No.
Well, nothing substantial.
No, maybe mention of, the ovaries stop working, but that's about it. Okay. In a 4-year OB-GYN residency, we get less than 1% of the 4 years on menopause. It is the most neglected topic on our planet, despite the fact that half the world's population spends half their lives in menopause. Now think about that. Half the world's population, half their lives, and it's the most neglected topic on earth. That's
amazing. That, I like that we characterize that because that puts context, and it's also surprising in OB-GYN, residency, you only get a very small amount of, because I would think that, okay, I trained in internal medicine cardiology, so I have an excuse, but I mean, my goodness, so the OB-GYN, that's amazing. One thing, we have a bunch of questions are lining up, but real quick, so just to wrap that follow-up question, so you use other biomarkers as part of your guide in terms of how much estrogen, in addition to how they went into menopause, whether it's
Exactly.
gradual, a sudden shock, et cetera, because that'll change what you do
Exactly.
as well.
Yeah, a woman who has premature or sudden menopause will probably need higher dosages of estrogen forever and ever and ever, amen, than the woman who went through gradual, you know, normal age menopause. I mean, it's just a whole different animal.
And when you start with the estrogen, you start with just, I mean, I know you said that they're good ones across the board. And when you're just starting from scratch, you don't know how this woman's going to respond. So
Nope.
would you start, I know you're not actively practicing, but you just start with anything? You just have your favorite or what?
Pick something or throw darts at a board. I tell women there are 4 delivery systems for estrogen. Pills and gels are daily. Patches and the vaginal ring are not daily. Are you a person who likes daily things or not daily things? That's start with whatever theoretically appeals to you. With progesterone, there are 4 options: a pill you put in your mouth, a pill you put in your vagina, a gel you put on your skin. All 3 are daily, or an IUD, intrauterine device, that your gynecologist puts in that stays there for years. Which of those sounds most appealing to you? The 3 that are daily, the 3 progesterones that are daily, all travel through your body and produce the typical side effects of progesterone, which are what we associate with early pregnancy and PMS. The weight gain, the bloating, the drowsiness, the acne, the depression, all that is all progesterone. Most women hate that. So if you don't want any of those side effects, you might want an IUD. It's the only one that keeps the progesterone confined to the uterus itself so that it doesn't travel through the body. It doesn't produce those side effects. And it, you know, kind of puts your uterus on autopilot so that you don't have to worry about uterine cancer. The one thing estrogen definitely causes is uterine cancer. Estrogen causes the lining in your uterus to get thick. Estrogen is like fertilizer for the grass, makes the grass grow. Progesterone causes it to shed. So progesterone's like a lawnmower. So when it comes to menopause, the key is either you take the estrogen and let the grass grow, and then you get the lawnmower and have a period, or that's called a cyclic regimen, or you do a continuous regimen where you have the fertilizer and the lawnmower there every day so that the grass never grows. That's called a continuous regimen. You never have a period, you never build up the lining in the first place. But that's the only thing that estrogen causes is uterine cancer.
So the woman that doesn't want to take pills and doesn't want to have the side effects of the progesterone will have an estrogen patch and a progesterone IUD.
If she wants it, yeah.
Okay.
I mean, you can use any combination. You can get as creative as you want. The key is you're going to start with something, and no matter what you start with, you're going to do a 2-month experiment, because the only opinion that matters is your body's. And your body is going to take 2 months to give you a verdict on any hormone. That's the way it works. It's not going to be quick, overnight, immediate, instantaneous, the way we all wish it were. It's going to be a 2-month trial. And in that 2 months, different things can happen. But by the 2-month mark, you'll know whether or not that option is a possibility for you, or whether you love it or hate it or whatever. But this is how each woman has to find what's right for her. We all have to find what is right for us, every single one of us.
Wow. Jackie, what are some of these questions?
Some of the questions. So let me just ask, if you've been off, if you've not had, you've been in menopause for a long period of time, is it ever too late to begin hormone replacement therapy?
Depends on the person. You know, the key is this: of the 3 body parts for which estrogen is involved with the aging process, your heart, your bones, and your brain. Your bones and your brain will always say, hallelujah, the estrogen's back. At any time, if you went for 20 years without estrogen and then start taking it, your bone and your brain would benefit no matter what. The only part of your body that can possibly transfer from a benefit to a risk is your heart. And here's how this works. It's like running. Let's say that when you were 20 years old, you were a runner. Let's say you were long and lean, you had no medical problems, and running was good for you. If 40 years goes by and you stay long and lean and you don't develop any medical problems, running is probably still good for you. Nothing's changed. But if 40 years go by and you gain 80 pounds and you get diabetes and high blood pressure and heart disease and arthritis in your knees, that's a different story. In that event, you're probably going to get hurt running. Running hasn't changed, but your body's ability to handle it has. So when it comes to whether or not you're still a good candidate for estrogen, it's all about your heart arteries. Are they still soft and supple where they can handle estrogen? Are they still adequately flexible to handle it? Or have they hardened so much that now they can't handle it anymore? This is where HRT can cause a heart attack if you already have the hardening of the arteries that made you a setup for it anyway. It's a timing issue, but we don't all age similarly. Some people age much more quickly than others. So I always say to women, go get a cardiac evaluation. Go see a doctor like Dr. Montgomery. Say, I want a cardiac evaluation so I know the status of my heart. I say they'll do an EKG, a treadmill test, maybe an echocardiogram, and you'll know the status of your heart. And I always say to them, don't go talk about menopause with the cardiologist. I go, they don't know anything about menopause. Don't have that conversation. Just say you want a cardiac evaluation and leave it at that.
Yep.
It's true, because I said, you know, they all they know is what the WHI scared you with, and they're going to say, oh, don't take it. I'm sorry, but a cardiologist's opinion doesn't matter. Because they don't know menopause. And I mean, it's just a matter of understanding that they know the heart, and they'll evaluate your heart, and then you'll know where you stand, and then you can just decide what to do. But that's the information. I think peace of mind is everything. And I think you should always get whatever information you need for your peace of mind, always, no matter what.
And so we have a question. You note in your book that cravings for sweets and alcohol can be related to menopause. This person asks if a person who is on a whole food plant-based diet and is doing a raw detox diet, so all raw, has a desire to eat all the time, especially sweets, might supplementing with GABA, tryptophan, 5-HTP, tyrosine, D-phenylalanine, and or glutamine help?
Any of the above could help, but I would say try each one individually. You know, one of the most basic things in science is something called isolation, which means you can only study one thing at once. And one of the big mistakes people make is they bombard their bodies with so many things all at once that there's no way to assess what's making a difference and what isn't. And so I would say, you know, try each one individually, separately, 2 weeks each. Don't do anything different for the 2 weeks, and see what effect each of those might have on your cravings. But to put it into context, think about it this way. Every hormonal phase of life is associated with craving. Think about puberty. Have you ever seen what a kid eats when they're going through puberty? I say it's all white. They eat potatoes, pasta, bread, rice, all carbs. Think about pregnancy. Crazy cravings. Think about PMS. Okay, every hormonal phase is associated with cravings. At menopause, the most common craving of all is alcohol. No one talks about it. There's women with alcohol in their water bottles and their mugs and stuff, and they start drinking early in the morning. Some of them, I mean, they literally crave it. And so it's the most common craving of all. Yeah. And if only they knew that, so that they don't think something's wrong with them. That's where education comes in.
All right, next question. How much estrogen do I start with? What product do I start with? I am 61 years old. I have hair loss, high lipids, anxiety, and then it says heart women, but I'm not sure what that means.
Well, in a consultation and in my videos, I teach you that the only kind of estrogen that can prevent heart attack, osteoporosis, and Alzheimer's is pharmaceutical estrogen. Nothing in the compounding world is capable. Nothing in the vitamin mineral world, or no food with estrogen in it. The only kind of estrogen that can prevent heart attack, osteoporosis, and Alzheimer's is pharmaceutical estrogen. The reason is that it's regulated. You know exactly what you're getting. Okay, it's studied, it's researched, it's regulated. There are many different kinds of pharmaceutical estrogen. For each and every one of them, there is a lowest dosage that is proven to be capable of preventing heart attack, osteoporosis, and Alzheimer's. If you ever, for the rest of your menopausal life, take a dosage lower than that, you are not protecting your heart, brain, and bones. That's all there is to it. So in my consultations and videos, I teach you what that lowest dosage is, but that doesn't mean it's the right dosage for you. It doesn't mean it's a recommended dosage. It doesn't mean it's the highest dosage. It means it's the lowest dosage that you can possibly use to accomplish your goal of preventing heart attack, osteoporosis, and Alzheimer's. This means that you can start wherever you want, but if you get lower than that, you're forfeiting your goals. The younger you are, the higher the dosage you'll need. Why? Because the younger you are, the more recently you had the bucket produced by your own body. You can't go from a bucket and expect your body to be happy with a tiny bit. The way it works is this. Before menopause, you have a bucket. When you go through perimenopause, the transition, the bucket becomes like a great big water bottle. Birth control pills give your body a big glass full of estrogen. All HRT is just drops. So you can't expect your body to go rapidly from a bucket to drops and be satisfied. It's not going to happen. That's just crazy. So it makes more sense to start high and then get lower if your situation warrants it. But unfortunately, because of the fear, most doctors will say, we'll start at the lowest dosage, and then it's like they start at dosages lower than the ones that can protect your heart, brain, and bones. And then you spend months creeping up, and you have to attach it all to a game of symptoms. That's insane, but that's the way they do it. So I teach you what that minimal lowest dosage is so that hopefully you'll at least start there, if not higher. And then you can see what your body has to say. But all day long in my consultations, women say to me, I just can't believe it. I mean, these are women who have watched my videos. They've had 1 or 2 consultations, and they're in that process of trial and error, finding what's right for them. And they always say the same thing. And it's so funny and cute because they go, oh my God, I just can't believe it. I go, what? And they say, the more estrogen I take, the better I feel. And I start laughing and I say, really, Mama Bear? Because I teach them that the 3 hormones are like the 3 bears, Testosterone is Papa Bear's hormone, and estrogen is Mama Bear's hormone, and progesterone is Baby Bear's hormone, because pro means in support of, gest means gestation, own means hormone. Progesterone is merely the hormone in support of pregnancy. It's there for Baby Bear. It was never there for you. It doesn't do anything for you. Your hormone is estrogen. So this is why when you take more, you realize, oh my God, the more I take, the better I feel. Your body is talking to you. Your body is saying, I love the stuff. Oh God, I want it back. But see, the women have been so terrorized that they have trouble believing that. I mean, they literally, they're just shocked that the more they take, the better they feel. And I'm like, well, what are you going to believe, your body or what you heard?
All right, next question. According to what I've read, Japanese women do not have a word for menopause because they do not experience the same symptoms American women have. Why do you think that Japanese women have a different experience?
The primary reason that Japanese women have a different experience, well, there's many, but one is they eat soy all their lives, every single day, and soy has estrogen in it. Number 2, they have much less body fat, generally speaking. Number 3, they have many fewer hair follicles and sweat glands than we have. And number 4, culturally speaking, in Japan, aging is revered. Aging is something of respect. Aging is laudatory, not disdained. All of those things add up to an attitude about it that is like, well, there's nothing. I mean, they just feel like it's not a big deal. We in the Western world are busy thinking that, younger is better and everyone's dyeing their hair and trying to look young. And so aging is a negative thing in our culture. And because of that, the idea, Western women associate the word menopause with aging. I said menopause is the most neglected topic on earth. The biggest problem of all is women themselves. Women won't talk about it. Women don't want to know about it. Women want to stay ignorant about it. How can that be? Menopausal women are the largest and fastest growing sector of society worldwide, but they aren't acting like it. They're sitting in the corner saying, I don't feel sexy anymore. We should be standing on hilltops and mountaintops saying we're the most powerful group on earth. But that's not what's happening. So the neglect is primarily because of women themselves. And until women get the education and decide they want more and demand more, probably nothing's going to change. I am the first and the only person on this planet to ever give women an education on menopause. That's horrible. We've been living routinely past the age of menopause since the year 1900. We shouldn't be saying it's neglected. It should be public health issue number one. But it isn't. It's not considered a public health issue at all. It's considered, well, it's natural, just deal with it. It's not natural. And it does ruin lives and jobs and all kinds of things. And the bottom line is women themselves don't want to talk about it. Well, that's a problem. Look at the Me Too movement. Those women came together and decided no more. And that wasn't a large group. We are a huge group. We menopausal women are very, very numerous and powerful. There's more than 1.2 billion menopausal women.
Well, perhaps this morning we can start the Mental 2 movement.
Really, maybe so. Well, we need a menopause revolution, that's for sure.
Wow.
Menopause me.
Menopause me.
Yeah.
One watcher is saying that at 52, they had a hysterectomy. And afterwards, her body felt angry. I'm grateful to know I'm not insane.
No, yes. No, you know what? I love it when this education reassures women. And every day on my YouTube channel and stuff, comments, women say, oh my gosh, they started crying when they saw a video that made them realize that they're normal and that this is not unique and that there is hope and that there's a name for it and that it all makes sense. And I just love every minute of my menopause education and the consultations and all the stuff I do because, I know I'm saving lives. I mean, it's not hot flashes, it's saving lives. And when women get this education, they start realizing that, and then they really, really get into it. And all these women talking about wanting to become menopause missionaries and getting involved. And that's how it should be. We should all be invested in this in a way for ourselves and for others. And my huge dream is for all women to get this education in their 20s. If between 20 and 30, you watched a video every week in order, because it's a real education, in order, you would know everything and you would know exactly what's going on when menopause comes about. I mean, most women don't know what menopause is when it hits them over the head like a ton of bricks and ruins everything about their lives. They have no idea what's happening. That's terrible. It's just puberty in reverse. Puberty is where you begin your reproductive life. Menopause is where you end it. Every woman should know that there's a bookend, and yet they have no idea. It's horrible.
Yeah.
There's a question about bone density, Jackie, above the one.
Yes. Would you speak the best ways to prevent bone loss and perhaps build bone density?
Well, it depends where you are on the bone density scale. Estrogen loss causes bone loss. It's a mathematical certainty, guaranteed. In the first 5 years without estrogen, women lose 2 to 5% of their bone each year, period. All because they lost estrogen. Okay. So you're going to lose bone if you lose your estrogen. The problem is there are no symptoms at all. And bone loss is all about quantity. It has nothing to do with quality. And the problem is everyone merges the two. So when you have a bone density test and it shows that you're losing bone and you're on your way to osteoporosis land, it's all about quantity. When your doctor says, oh, take your vitamin D and your calcium and get some exercise, that's all about quality. It's not going to have an impact on your quantity. You have to separate things out and understand that they are different. There are different goals. The best thing to do is never lose the bone in the first place, but you got to know that you're going to lose it when you lose your estrogen in order to do that. And women don't know that. I get all these health nuts in consultations. There are these women who have these beautiful bodies. They're all fit and muscular, and they have beautiful skin, and they have perfect diets, 100% plant-based diet. And they come to me with horrible osteoporosis in tears. And they always say, how did this happen? I do everything right. And I go, well, you're correct. You do everything right. But you forgot that nutrition is nutrition, exercise is exercise, and a hormone is a hormone. And they thought that with their beautiful exercise and diets that they didn't need to worry about it. And they fall prey to horrible, horrible osteoporosis. Well, if you've already lost bone, depending where you are on the scale, the only thing left to build bone are bone building medications. There is nothing else, period. So all these product pushers and promoters of this and that and exercise programs, no, that stuff, it's too late. Those things work when you have normal bone. They don't work once you've lost bone. So people are falling prey to all kinds of misinformation, scams, product pushing, you name it. I just teach them all the facts, and the facts are what are going to make you able to be successful. If you're falling prey to products, you're never ever going to be successful with your goals. It's just, you have to know what you're doing.
Do you come to Houston to see people? No. And how can people get your assistance?
I live in Nice, France, on the French Riviera, and I, at the very most, come to the United States for a medical conference about once a year. And I developed this great big 2-day seminar, but I've converted it into webinars. So now what I do is I do consultations, and I do them all online. And to schedule one, you go to menopause.tailor.me. You schedule it. I have you fill out a 17-page questionnaire with all your information and details. You're going to answer questions about everything. And you submit it to me. I create a document from your questionnaire. I give you the whole education in the document, and I put your information in red so that you see how things apply to you. I send it to you 4 days before the consultation so that you have time to read it. And then in the consultation, you can use that time you can use the document as a launching pad so that you can use your consultation time much more efficiently. And we do whatever you want to accomplish in the consultation. And then you just schedule consultations whenever you need to tweak or fine tune or adjust or do anything. And the women love this system because, I mean, if I didn't write the document, they would have to remember everything I said. And of course, I write them about 100 pages. It's a lot of stuff, but they've got it. It's a resource they go back to again and again and again and again. And it just gives them the facts, and it makes sure they stay focused on the whole truth instead of hearing this and hearing that and trying to make sense of it. Because when your world is full of sound bites, you don't connect the dots very well. You can't.
All right. So next question. I am 72 now and did not question my urogynecologist at age 42 when I had my hysterectomy. And he said not to risk ovarian cancer and another surgical procedure and have my ovaries removed then. So I assume she had her ovaries removed. Can you nod? Yes, you had your ovaries removed? Yes, okay. Will oral hormone replacement therapy, or I would assume beta, any kind of hormone replacement therapy, start it now, help in ways that I'm not really aware of? I know my short-term memory is increasing dramatically in the last, do you mean decreasing dramatically in the last 3 to 5 years? Okay, you wrote in, right. So decreasing in the past 3 to 5 years. My obstetrician had me stop oral Premarin because my mother and older sister had strokes.
Well, first of all, it doesn't make sense for you not to be able to take something because someone else had a problem. That's just insane. Okay, you're not your mother. You didn't have the stroke. Okay, so that kind of thinking is ridiculous. Secondly, you can do whatever you want, but I would say you're in that situation of what is the status of your heart? So find out the status of your heart. If your heart's in good shape, then you're a candidate for whatever you want. Okay, if you find out you have hardening of the arteries, then you might say, well, gosh, your benefit and risk ratio changes a bit, and then you have to decide what's your best way of going about this. And you can always do whatever you want. You just need to know what you're doing. You need to know what your benefits and risks are. So I would say go to Dr. Montgomery, get a cardiac evaluation. And if he says you're all clear, your calcium score is great, your arteries are great, wonderful, you're in good shape, then you can do whatever you want.
And to dovetail on that, if you come to me and you say, well, hey, these things aren't great, there are things you can do to make them great.
Yeah.
So there are things you can do lifestyle wise with exercise, nutrition, et cetera.
Exactly.
If those arteries are not, if they're not soft, to make them soft, et cetera, then you can tolerate the hormone. So it's not my arteries are bad, so I can't do this. No, and that's why we look at an integrative approach.
Yeah.
And that's why we have a medium like this, where we bring experts in different areas and we sort of put this information together for you.
Yeah.
So I really like that response. That's great. Great question also.
Yeah.
How much more time do you have, Dr. Taylor? Because we have more questions.
I'll tell you what, we're almost done. I'll tell you what, why don't we end it at the question of should I get a heart assessment for a consult? That's already done.
Yeah.
What about weight? So really, I think we just take the next 3 questions. I think we'd be good.
Okay.
Okay. Can you do topical estrogen and topical progesterone together at the same time?
Of course, you can
Or
be as
different
creative
times?
you can be as creative as you want. There are women who use a topical estrogen and a pill with that is estrogen. I mean, some women find that different products benefit them differently, or their bodies use them differently. Some people absorb one faster than the other. I have women getting as creative as they need to in order to meet their needs. For instance, let's say you take a pill in the morning and you feel wonderful all day, but by golly, you're still waking up at 2 a.m. every single night. What does that mean? Well, it means that you're running out before the end of the 24 hours. There's ways to handle that. You can split the dosage, or you might want to add something in the evening. There's all kinds of things you can do. Your body is telling you that it's using up all the estrogen and you're running out. It's like insulin-dependent diabetics. They have to figure out when they take their insulin. They have to make sure they take it in order to keep up with how much their body is using it. We all metabolize things differently, food, hormones, everything. And so part of the journey of menopause management is figuring out how your body uses the stuff.
Wow. That's I think on that note, we can wrap this up. These some follow-up questions of things that may have been answered. I think the cost of your consultations on the website.
Yeah.
And I think getting a heart assessment before the consultation would be great, because then you come in with more information for Dr. Taylor to use. And exercise is good for increasing bone density. However, if you need hormones, then you need the hormones along with the exercise. So these are great questions, Dr. Taylor. I've learned a lot. So
you did.
Absolutely. And I'm taking notes here. So
I bet you're jealous. I bet you're jealous that you're not going to be menopausal.
Well, no, I'm not going to go that far, but men, we have our own problems, but I'm not going to go that far. But the point is this: so I'll have an honorary membership to the club. How about that?
We make you an honorary member
just for helping put this conference on. This start the movement out. I could have an honorary membership. How about that?
Excellent.
But seriously, it's an excellent topic. I mean, you put things in perspective so well. And I think that's really the most important thing that I've learned as I've matured in my clinical practice, is to always step back and put things in perspective. And I think as healthcare advisors, or people who are getting advice, you should always step back and put things in perspective, because that helps you line up the dots appropriately. So I really love the way you do that. And so this has been very enjoyable. We really hope to have you back. There are a lot of things that someone wrote that book is humongous. So I'm sure there's a lot we didn't cover. So anyway, so one of these days, but no, I really learned a lot. And actually, I mean, it's influenced my practice. I get a number of women, because we do practice a little bit outside of cardiology and wellness. And we get these questions. And so, I'll be less hesitant to prescribe hormone therapy or recommend it to patients because of what I've learned today. So I think I really thank you for that. This has been fantastic.
Well, thank you for having me.
Great. This is wonderful. Jackie, any final comments or
So in the chat are links to Dr. Taylor's website, her YouTube, and her book. And so when I post this, the recording of this in the community, I will include the chat. So you will have that chat as well to refer to. And so thank you so very much, Dr. Taylor.
Well,
I
thank
have a
you.
quick
You all were
question. I have a
very-
quick question. I'm sorry that I didn't think to ask it, but I'm 70 years old. I'm still having hot flashes. Is that normal?
Oh, some women have them for the rest of their lives.
Okay. Thank you.
All right.
Great,
Good
great.
final question.
All
deal.
righty.
We'll
Thank
end
you,
with that.
everybody.
Y'all have a great day. Have a great
Thank you.
Thank you, guys.
Bye.